which we decided to codename Learning and Adaptation webinar series on integrated health services. And we decided to be more practical because sometimes, even if Dr. Andrew and all those who are practitioners like me in surgery, that if you don't do, even if you see it 1,000 times or 2,000 times, you can't be able to do it. So the test of it is really in doing it. So we can only be able to improve it if we do it. But also what we know is that different regions and different health facilities are at different levels. And so integration is also not something which is like one shoe which will fit all. So they will be at the different levels. So we saw that there are many lessons which we would want to be able to pick. And I hope the teams which are doing documentations are picking these pieces, which probably we had interaction with Gulu last week. We had now, I mean, with the Acholi region, this time we're in Lango. I think we had Mubende, we had Entebbe. So we thought definitely that we should be able to move now to all the regions. And so then afterwards, we shall leave these things on at self-drive. We'll definitely leave them that we don't now need to be the ones at the ministry to conveying them. We think that the regional integrated care system itself should be able to pick itself. For us now, we'll be waiting for high-level briefs or summaries. And also, I wanted to introduce Charles because Charles is the one who will be able to person coordinating the Lango region. I'm still looking for who is together. He is in actually Dr. Penso and Dr. Opigo. So I'm still looking at who is going to be the one driving it. But definitely the chair of the system is the director of the hospital, assisted by one of the co-chairs, definitely one of the DHOs of the districts, one of the districts. And so we shall be revolving. So then we'll expect the partners, we expect all their different system, malaria, TB, all our partners, ambulance, EMS services, all of them to be able to integrate it. And I think we're trying to build from the local market network. All of you know the local market network has been a lead and they have been able to improve services for mothers and newborns. But we think that that should not be, we should not run that in isolation. We should run it at a whole system. We should be able to improve. The only challenge I have is that our numbers are still low. Look like people are always, because these meetings we want to allow you, we don't want to keep you for a long time. We wanted to run them specifically for 1 hour from 8 to 9, and so that we can allow you to go and do what? To do the other activities. So I want to once again thank, I think as Andrew this year, who definitely will be able to pick up what they are doing and doing better and what can be improved. And then we want this cascade. So if the performance is across board, if the integration is across board, then you'll be able to see that patients will be able to seek care in the facility which is nearest to them. We also but I want to definitely to highlight that even integration will need resources. So we shall still look for resources. We shall still look for additional human resources. So I think last week, the director of the young hospital was doing a recruitment planning with the Health Service Commission. So we will still continue to do it. It does not mean that now the few staff will have to do all. We still will be able to see that we advocate for more resources, we advocate for more medicines, but how do we optimize what we have? How do we avoid duplications? How do we able to be able to run the facility so that we do not have highlands of excellency, while other places in the facility are not doing the same. So thank you, Chair. And I want to allow us that so that we can move to the, you will move on so that we can receive the presentations. But we hope other people can be able to join as we move.
Thank you very much, DG, for those remarks. It's very important. So, colleagues, you will agree with me that from the remark of the DG, we are together in this. So it's our responsibility to shape the health system in this country. So there's nothing like leaving it only to the ministry or blaming somebody that you didn't do this, or so it is all of us. So please feel free to contribute so that we make this much better for us as we keep learning. So with that, I would like to now take us through the next agenda item by ushering us into the presentation by Dr. Odu, the Senior Executive Consultant, Lira Regional Referral Hospital. So, Dr. Odu, you're most welcome. I don't know how much time you're giving him, Secretariat. How much time is the presentation?
About 20 minutes.
All right. So you have 20 minutes for the presentation, then we'll go into the discussion. Thank you very much. The partners that are on the call, you're most welcome. So please proceed. Go ahead.
Thank you very much, Chair. I was hoping that Cordelia would share my work from that side, but let me.
Cordelia, is it possible?
No, we
All
really
right.
want them to own, yes. If you have it in your side, please share, yes.
But we have the presentation, right?
Yes, we have it. I would need to get it from somewhere. Dr. Andrew, if it's okay, please share.
Okay, I'm trying to get a challenge here with my device.
Oh, sorry. So
Okay,
let's come to his rescue, please, so that we don't waste time.
Can I share?
Yes, go ahead. Go ahead, please.
All right, I think as Laban is sharing the presentation, I'm going to start the preliminaries. I want to take this opportunity to thank the Ministry of Health through this initiative of integration. I think this is taking us far, and as a country, service to our clients will be improved with the constraints that exist within our systems. We'll be sharing experience from the Lamu sub-region, the work that is going on within the region, both at the regional referral and the rest of the districts within Lamu sub-region. I'm called Dr. Andrew Odu, the Acting Senior Executive Consultant for the Regional Referral Hospital. Laban, next. We have a brief outline of our presentation. We'll look at the background, but most importantly, we will be delving more into the results and some opportunities that exist within the region. Next. Lira Health Region, which is also, you could actually call it Lamu sub-region. We have 9 administrative districts and 1 city. And of course, that means we serve a population of 2.65 million people. We have a number of facilities providing ART and PMTCT. We have 156 facilities reporting through the routine client satisfaction survey, and this is actually a very big number, absolute number of 18,000, contributing 14% to the entire country assessment. This is something that we are proud of as a region. And then in the financial year 2023-24, one of our administrative units, that is the Lira City, emerged as #1 in performance on the league table. We continue to collaborate with the Ministry of Health and other partners to implement health service delivery. Next, Laban. If you look at this slide, we'll basically show you some of the achievements obtained through the integration system. And at the regional level, we were able to train 48 staff at the regional referral to take lead at the departmental level, because we knew that leadership is going to be extremely important. So looking at the different departments within the regional referral, we needed change agents to be there so that they can drive the integration agenda. We have also conducted meetings with the frontline health workers, and we specifically assigned the community health department the head to coordinate integration in the region so that we have key deliverables.
Dr. Andrew, have we lost you?
Can you hear me now?
Yes, we can hear. There's a short break, yeah.
Are you able to hear me?
Yes, we are able.
Me?
Hello, please. Go ahead. Dr. Andrew, I don't see your mic. I think there's some challenge that side. Hello.
Mic is muted.
You can hear me now?
Yes.
Yeah, you are back.
Yes. Yes, Laban, that slide, yes. So we created a WhatsApp platform that interacts with the entire region, and we're able to look at the events unfolding within the region in regard to integration from time to time. At the district level, we had a TOT, and the DHOs, being the drivers of change within the districts, were trained, and 340 district staff were trained in regard to implementation of integration. We have also had to involve the politicians and the technical leaders like the COW so that they give us reinforcement as we integrate. The DHOs have been actually very active in participating in mentorship and support supervision. We have had cross-learning with our neighboring districts, and each district was mandated to assign a focal person for integration. At the facility level, we conducted pre-training facility assessment, which we are going to see the results, and we conducted the training at 102 sites, except the upgraded sites. And of course, if you look at the cumulative number, 1,700 frontline staff were reached during this training. Next slide. When you look at the integration domains, Laban, you move to the next. Looking at the integration domain, under leadership, of course, we formed the committees with a focal person in place. We now conduct bi-weekly meetings to discuss progress at the regional referral. We have been able to review our work plans and hold our weekly meetings. You look at the service delivery, we have sensitized patients, and that is in regard to the integration. and we have trained staff on service delivery. We have had some of the IEC materials developed that speak to integration and establishment of support groups for chronic care, including properly understanding the client flow within the outpatient services. This we had to do together with all the clinicians and the stakeholders within the facility. Looking at the supply chain, we established a dispensing point in the chronic care clinic. This would help us eventually to ensure patients access their prescriptions in time. And of course, since we have been implementing digital HMIS, dispensing of medicine and accountability is therefore also through the EFER system, which the hospital is implementing to go paperless. Looking at HMIS domain, of course, use of EMR and EFER is ongoing, and we've been having regular reviews of our performance, and the key indicators are being tracked. Under human resources, which is usually very critical in regard to integration, we had to make sure that the government of Uganda staff are fully informed, fully assigned, and schedules of duties are very clear for attending to patients in the chronic care clinic. Of course, we are providing mentorship to them to build their capacity, because some had stayed for years without interacting with HIV conditions. And so it's been a transition time where we had to onboard them, and they get to know this. Under investigatives, of course, just this week, we have been working with the lab to see how do we move a bigger chemistry machine with a bigger capacity, so that is able to run some of these vital tests in the chronic care clinic. And we're working together with the laboratory, but already we have tests available within the chronic care clinic that the patients are able to access from time to time as clinicians deem fit. Community systems, we've been able to train community workers on integration. Although there's still some work to be done here, we need to continue to realign them to the interests of integration and under quality improvement. The work improvement team meetings have been instituted, and speaking to integration, they have been able to open QI projects that monitor progress of integration, but of course, assessing how satisfied the clients are is also an item that we are following very clearly. When you look at improvement over time, you look at the domains that have been assessed. If you look at June this year, we see quite a number of yellows and some reds. And over time, with all this work being done within the region and in the regional referral, in September, the assessment has showed a significant improvement. As you see, we are greening our dashboard. Although there's still some work to be done, we believe that we should be able to do even much better, especially around service delivery, and then working on community systems that I mentioned earlier, and of course, strengthening quality improvement so that we are able to implement what works within our regional referral and the other facilities. Next slide. You would be interested in all these questions of integration. What are the clients saying? We are routinely seeking for how satisfied they are in the chronic care clinic, and of course, they've been able to give us their thought on how they feel they're being supported. From July to September, we have had feedback from them. And you look at, there were issues of availability of drugs, and they wanted medicines for other chronic conditions. Of course, they were concerned about time management, and all these comments brought by clients, we have been able to sit down during our WIT meetings to ensure that we find solutions and make it better. I believe in the subsequent assessment, we should be having most of these issues dropped off as being solved. Next slide, Laban. So I mentioned earlier that we did a pre-training assessment, and 41 sites were assessed. Interestingly, more than half of these sites had already started implementing integration on the chronic care model. And if you look at this slide, therefore shares what is happening in all the domains of integration. And this was very informative. It helped us to know how we can support these facilities better. Next slide, Laban. Yes. So the Ministry of Health also has been visiting the region, and they've been able to open our eyes to some of the challenges that exist within the region. But by and large, if you look at the dashboard on the lower side, you'll be able to see that our districts are faring well. We had assessment of Leptong, Apache, Oyam, and all those districts already started integrating their work plans, and support supervision to the facilities being conducted. We still had some challenges with districts documented and shared best practices on integration. Yes, so 5 sites that received post-training follow-up because we needed to know. So if you look at August and compare with the downer dashboard of September, you see a significant improvement. Still consistently, we have challenges on the domain of service delivery and on quality improvement. I think this is what the data is showing us. And as a region, we are going to refocus on them and see how we can support the facilities better. How do we improve on the service delivery domain and the quality improvement? But the rest of the domains are faring well. We are integrating the human resources quite better, and community systems are being brought on board, and most of the facilities are actually repurposing the PHCs properly to address issues of integration.
Doctor, you have 5 minutes to go.
Yes, I'm almost concluding. If you look at a success story in Abuja, Abuja is in Apache district. They have been able to work around the issues of integration very well, and we learned from them that they have utilized their human resources very well. They had only about 4 people dedicated to HIV/TB work, but now they've onboarded all their staff, and they're able to continue to provide service to the clients. What are the drivers of success for integration in Lango sub-region? One is that leadership is very, very critical, as we have learned over time. The DHOs do chair these meetings, they are in touch with the facilities, and therefore it strengthens the accountability within the health service delivery. Of course, we are learning from each other, and this motivates us to do even better during our platforms and presentation. We also had issues of integration discussed at the joint review missions, and this helped us to identify what actions to be taken as a region. There are still some challenges though. The DG already talked about human resource challenges within the health sector. And of course, looking at the regional referral, under G2G, we had more than 150 staff. But remember, when these were taken off, you can imagine from 150 to 0. It's a big, big dent in the HR support. So the system is struggling, but we hope that we can be able to onboard over time and get this better to support the clients. Of course, we have some challenges with the NCD support for their commodities, but this through procurement planning, we'll be able to work on this from time to time, but also advocacy to see how we reach this gap. And then IEC materials needs to reach the community level so that they understand what we are doing. The EMR, the Uganda EMR is not yet fully integrated into EAFIA. So this is a big challenge on ground. I hope that the developers needs to be talked to so that they support us to make this easy. And then, of course, the hard copy register tools is still a challenge for facilities that are not yet implementing the EAFIA. Capacity is still low among other health workers. So in using digital systems, we need to continue to do this. Next slide. The opportunities lie in the ability of the health workers to embrace improvement, quality improvement, and this is something that we need to harness and work with as facilities. The integration of the health workers, giving them shifts in their tasks has been beneficial. They have been very interesting in working in chronic care clinics, and they're learning. So I think this is a good opportunity to continue to develop our health workforce to embrace health in totality. Of course, focusing on the patients. If you look at the routine client satisfaction assessments, this helps us to identify how to care for these patients. This is a very good opportunity to improve service in our facilities, even through the barazas that are happening, client satisfaction surveys within the facility, and dialogues within the communities. As I conclude, integration of the digital health solutions are very, very important. It makes work easy, and of course also engagement of the community, so that we have one message. The health facility may have a good message, but also the community also needs to know the same message within the facility, so that health-seeking behavior improves from time to time. Our next steps as a region is to continue to share best practices across all the districts. Those that are doing well, we learn from them. We continue to build the capacity of health workers, and also use data to drive decisions on which support, supervision, and mentorship to be conducted across Lango sub-region. Thank you very much. We appreciate all the partners that made this happen, and we appreciate health workers within Lango sub-region and the district leadership. Thank you very much, and over to you, Chair.
Yeah, thank you. Thank you very much. Let's clap for him for really very wonderful presentation. I hope you will agree with me that this has been very, very fantastic. Thank you for keeping time. And without diluting anything, I would like to open up the floor for discussion. And as we do that, I have to confirm that the presentation that he has given is a true reflection of what is happening in the region. I happen to lead a team there for our support, supervision, and integration in the month of September. And exactly we confirmed those findings, both in the regional referral hospital and also the districts in the region. So please, thank you, keep it up and continue doing the great work. Somebody's saying you share the slides, hopefully, but you can keep the slides open so that I can quickly refer to in case of any areas of clarification. So the floor is open. Please, you put up your hand and you raise your issues. Be precise and to the point. Who is taking the lead? George, you have any comment? George Patrick Akabuai. Oh, sorry. All right. Members, I hope you have been following the presentation. If you have any comments, any questions, it is welcome.
There are comments in the chat.
Yes, Dr. Kenneth. Go ahead.
Thank you, Chair. Please confirm you can hear me.
Yeah, we can.
Okay, great. Good morning, colleagues, and many thanks to Dr. Andrew for the excellent presentation. I really appreciated the system with which the region is making a good progress with integration of services and also the measurement component. I would have asked about the different indicators being used, but maybe I can follow that up on a separate note. I noticed though that the client satisfaction was going down, particularly the month of September at 29%. I was wondering whether this was for the regional referral hospital or the entire region, but also it begs the question on whether this patient-centered model we are trying to implement is instead affecting the satisfaction. I don't know if you could comment on that. Thank you.
Yeah, thank you. So please, Dr. Andrew, you take note, you respond later. Let's hear from Medad.
Yeah, good morning. Thank you very much for the presentation. I have two comments. One, is there an opportunity to look at the percentage of the resources we are saving through the integration? Then two, considering the different disease complications, do we have specific lessons we have learned, especially between the integration of ART and other OPD programs to come out very clear during the integration as part of the take-home messages? Thank you.
Well, thank you. Any other comments? Simon, following your mic is unmuted. Do you have any question? All right, let's hear from Anne. Then we come to Commissioner Stavia and Esther Igonyo, then Warren, in that order.
Thank you very much. My question is on the integration of TB services. At my facility, we are, I'd say maybe 80%, but we still have a huge challenge with TB, especially because we are also an MDR site. How has LIRA approached their TB patients and TB services with the rest of the services? One, and then two, how are you tackling the issue of EMR or EAFIA with Uganda EMR? For us, the biggest challenge is that we keep entering data twice is really problematic. I can understand how the problems, especially with the reduced staff that we've had to have this year. So this perhaps is for ministry. What are the practical things that are in place? How quickly is the integration going to happen so that we can then...
Simon, can you mute your mic? Esther, unmute your mic and go ahead. Sorry.
Thank you very much, and good morning to everyone. My question is, according to Doctor's presentation, he has talked about the EFR and the EMR for data management. How about for lower facilities that have not yet adopted the use of the digital platforms for managing the data system? How are they doing it? For example, we've been having facilities with capturing data on client files as regards to HIV clients. How about these other chronic care patients? How are you managing their data? How are you retaining their data? Thank you.
All right, thank you. Yes, Warren, your hand was up. Have we lost
Okay,
you?
thank you. Yes, thank you, my brother, Dr. Dul, and the whole of Lila region for the good presentation. A few have been asked that I had on my list, but one other one is, I think slide 2 or 3, where I looked at how you are doing it as a regional fellow, Lila, regional fellow, perfect. And then district, and then facility level. I missed out the presence of the IPs, because in other regions we still have them, especially facility-based health center 3s, health center 4s, and somehow the general hospitals. So for regional file as I liked it. It could be slide 2, slide 3. How you categorized it. Okay, anywhere there. But I wanted I missed out the contribution. I missed out the effect, the impact of the IPs, especially for the lower facilities. If they were, maybe I missed it. If they are not, maybe it's something to consider, because in other regions we have seen them really do a great job, especially in support of integration, to do with the training, rather client satisfaction, to do with the training, especially in the lower facilities of health center 3s. Here, and then Uganda EMR, somebody raised it. And then what about the issue of some clients?
Please summarize.
Yes, some clients not being able to use the QR codes. How have you been able to handle that, especially in lower facilities? People have these other small phones. Others claim not to be having data and the related things. Thank you.
All right, thank you. Members, I remind you once again, let's be brief to the point. Yes, David Soro. David, you're muted.
Am I audible?
Yes, please go ahead.
Yes, I'm David from Kabale Regional Referral. My concern is, at the beginning of this year, we received the revised AD card, which wasn't adequate enough. And currently, the new reporting tools is updated based on the card. Now, if we are to go digital, the current EMR system is not updated to the new reporting tools and the cards are not enough. So if we are to go digital, I've asked the Ministry of Health to update the EMR and integrate it with EAFIA to make life easy for the regional referral, which is going to the paperless direction. Because I asked my team, if we are to report to the new tools, do we have enough cards to transition the whole clinic to the revised AD cards? We don't have adequate. So that is my humble appeal to update the EMR and integrate.
Thank you. That is noted. So members, the rest of you can put your questions in the comment, in the chat, so that we don't spend a lot of time on it. We just read and they'll respond to that. Let's pick the last one. Christian.
Thank you. Good morning. Can you hear me?
Yes, please. Go ahead.
Okay. Thank you very much, Chair, and thank you for the presentation. My first question goes to the issue of the improvement score. Can you briefly explain how we are using it? Because there was 100% on some domains like lab and diagnostics and HMIS. Then my second question is on the challenges with service delivery domain. You mentioned that you are having challenges. Can you just briefly say what they are and what you are proposing to deal with them? And then on the issue of the HR distribution, you said you are distributing tasks among government of Uganda and partner-supported staff. I just wanted to know what proportion of the HR staff is the partner-supported staff, given the fact that we might have challenges with having partner-supported staff being available all the time. Thank you, and over to you.
Yeah, thank you. So members, for now, let's stop here. We are going to have another round, depending on how we manage the remaining time. So Dr. Andrew, please, you respond to those concerns, but there are some questions that have been raised to the ministry. I don't know whether Dr. Kodedia or Dr. Stavia is on the call, or or Paul Mbaka from DHI to respond to EMR issue. Where you have failed to respond completely, we still have DG with us. You'll be able to give some answers. So over to you, Dr. Andrew.
Okay, Dr. Andrew, I think I request that I go first, then maybe you sum it up.
Yes, Laban is one of us, so please answer all the hard questions.
Go ahead, Laban.
Okay. Thank you so much. I want to start with the question of EMR, IAFIA, and data entry at lower facilities, how it is being done, especially when they don't have the digital systems. At the lower facilities, they have improvised some registers. A majority of the sites are using the OPD register to capture as well that data for ART as an integration mode, and they are able to document using such an improvised register. We have mentioned it as a challenge. If we can get a better worked on register, it would be a very good paramount. Then one person has asked about the presence of IPs in our facilities. We do acknowledge that our IPs are supporting us right away from the time of regional TOTs. LPHS, Kigezi, Lango, and the URC UHA has been on top of it, even up to the facility level mentorships. We are working together and doing joint visits to the sites. So any contribution that we see is really highly contributed to by also the IPs. Then one asked about the QR codes during interviews, how clients are able to use them, most of them having no smartphones. Yeah, it's true. But at lower sites, we also have the staff supporting this function. And where the clients do not have the smartphones to scan the QR codes, the staffs are also doing interdepartmental exchanges to be able to support the interview of clients, and also in relation to use of the manual tools where data is entered after. The other question was about the improvement in the domains. How are they being calculated? These domains, we realize that they have standards, and the standards vary according to each domain. So we look at how we have improved in one of the standards, and then the total standards in that domain becomes the denominator, and we see where we are excelling well. That's how we are getting these percentages. And then one person asked about the resources. How are we, is there anything that is being done to see whether there is a saving as integration is ongoing? This is something that we are studying, and we acknowledge that our partners are also supporting this function to do cost-saving analysis, of which will come in along with time. So there are some measures being taken to understand whether resources are being saved in that relation. The IPs are working on it with the lead of URC-UHA. And then client satisfaction at the regional referral hospital going down amidst the client-centered model. Yeah, we understand this, and it is critical that we are aware, trying to look at what the clients are saying. And as the presenter said, we are critically looking at their issues, and we hope that this one is going to improve. Andrew, I call upon you to add it up where I have stopped. Thank you.
Yes, thank you, Chair. I want to add on my voice to involvement of senior staff. Personally, as the head of the regional referral, I had to have direct meetings with the groups of these health workers, including the specialists, because now when we bring chronic care clinic, we are teasing out conditions that actually require a lot of specialist involvement, the medical doctors involvement. So it was a deliberate effort to ensure that we onboard these people. Of course, they also have other roles in the other departments, but they have been very supportive, and they have schedules of how they attend to the duties there. The duty rota is available for who is going to be at the chronic care clinic and when. And we have ensured that we keep an open consultation between the team there and the team on the other side of the government of Uganda patients, the wards like that. So, of course, the other NCDs being integrated, we feel this is a good move. At least you have patients being attended to holistically, and then we believe this in the long run will also reduce on the stigma and discrimination of the patients. The other issue is about the AMR EFIA is still a challenge. At the moment, within the regional referral, we are using both systems. Both systems, when a patient comes and requires you to use EFIA, that's what you go for. And when you need to use EMR, the Uganda EMR for HIV care, you switch. So it's tedious. We would wish that through the DG and Paul Mbaka, we really do something around the disintegration of the systems. The lower facilities that are not using EMR, of course, we are still on hard copies. And they have done a lot of innovations to capture the necessary information from the clients. I'll go through some of the questions on the chat, and I think one of them is talking about some challenges in the QI domain. I think this is work in progress. We continue to interrogate some of these results and see as a team where we put more efforts. Of course, funds were cut from the HIV clinic. So right now, attending to chronic care is just like any other department within the hospital. So that is the message that we are passing to the staff, that there should be no difference. Even when in the future we get more resources dedicated for this work, we do not wish to see sliding backwards to specializing HIV as HIV alone and TB. So this is a message that we are very firm on ground to ensure that we don't backslide, if I may use that word. I think, Commissioner, Chair, those are some of the responses that we are able to provide. The rest, I think, we'll continue discussing as we go along. Thank you.
Yeah, thank you very much, Dr. Andrew and Dr. Laban, for the responses to the comments and questions raised. Colleagues, this is the integration agenda, is a journey. So we can't say that what we have shared now probably is the final veto is like one size fits all. We keep learning as we move on. So I thank you very much, Team Lira, for all those efforts that we are put into the integration agenda. Ronald, you have, yes,
hello.
We are
hello.
running out of time. Please, Ronald.
Chair.
Okay, oh yeah, Dr.
Chair.
Stavia, please. Yes, Dr. Stavia, go ahead. Go ahead.
Yeah, thank you. And I'm very happy with Team Lango, thank you for the progress you are making amidst the challenges that are there. The challenges are part of the reasons why you exist, and I have had firmly that you are set to solve them, those that are within your means. I wanted to give some guidance. I saw in one slide, I was checking to see if the Commissioner Lab is there, where you want to move machines from the main lab to the chronic care clinic. I think the lab services remain central. You can only pick the samples and they're tested in the central space where the equipment is, unless you have challenges with that. And you really have to move the machines into the chronic care clinic. Then there's also someone who has challenges with how to handle TB. I don't know if the training package was clearly understood. Our first slides were talking about getting people who have emergencies and catering for them, and also people who have infectious diseases. And TB is one of those infectious diseases, and others. So with the integration, we have not removed the IPC standards. We have to observe IPC. If anything, we need to advocate if we do not have isolation space for such people with infectious diseases in our facilities in future. Like the DG said, we will need resources. So those are some of the things we need to keep at the back of our mind. If you have been having a TB clinic, you don't have to close that clinic. If anything, that can be where you are seeing some of the other infectious conditions as well. We are not saying all people with infectious disease should be seen in one space. No. IPC must be observed at all times. Then I also noted the focal point being the community health, the head of community health, which is very good. But the chronic care clinics, these services are clinical issues. He can do the coordination of other functions, but I would and want to understand how the physicians in the hospital are involved in the chronic care arrangement. Thank you.
Yeah, thank you. I think those are guidance. Unfortunately, the Commissioner Lab is not on the call. I don't know whether we have anybody from CPHL here, but nevertheless, I think. Wow. Sorry. I retract that statement. Yes, Commissioner Lab is on the call. Yes, Dr. Susan. Please,
Good
you're most
morning.
welcome. Yeah,
Thank you so
speak.
much, Chair. Good
Thank you.
morning. That has really been a question in this integration journey, and we are handling case by case because depends on the infrastructure of the chronic care disease where it has been placed. But in some we've guided and we are deploying what can be deployed, the point of care. But there are some tests that we're trying to link to make sure that the lab in OPD speaks to the main lab, and some of the tests cannot just be decentralized for purposes of a number of things. So we are handling case by case to see where we can put what. For example, in Gulu, we decided to put some equipment, high throughput in the chronic care clinic, OPD clinic. So it's a case by case, and we are supporting the lab teams with the leadership of the hospital to see what can be done where. And also in Lira, we are doing the same. So it can't be that the case is the same everywhere. So we are handling case by case, especially for the regional referrals. For the lower facilities, it will still remain one lab because of the infrastructure. So that's the guidance we are giving, and we are handling case by case. We can't say transfer all these. Some are very high throughput, big machines, no infrastructure in the OPD. But there are some POCs we are advising and we are putting in the OPD. But we are trying to make sure that OPD lab is linked to the main lab electronically such that results can quickly return, but also try to have a runner for some of the high throughput tests. I hope I've given.
Thank you.
Yeah.
Thank you very much, Dr. Susan, for the responses. Ronald, is that really very burning, eh?
Yes, I just wanted to make some clarification. Thank you, Commissioner.
Thank you.
Thank you, Commissioner, for giving me this chance to take. And I want to thank Dr. Odul for steering integration in the region. I'm called Dr. Ronald Misinde. I head the Committee of Department in Regional Referral Hospital. One thing from the supervision, we realized that I think we needed to work faster on the integration registers. Because at one facility, we went to a high volume facility. We found a clinician with so many registers in front of them. So whoever was coming we first have to look for a register they fit in, and then they put their names in there or their particulars. So we needed to really move faster. And I call upon the ministry to move faster with maybe integration register, or we move faster with the digitalization of the process. Then just to note, at the regional referral, the lead in the integration, the focal point for the regional referral is a senior consultant pediatrician, that is Dr. Young. The Committee of Department coordinates the region in the integration activity. And that one, I think, I want to just make it clear. I think that is it. Thank you very much.
Thank you. Somebody posted a comment that question that where does infrastructure lie in the integration domain? Who is responding to that comment, or we leave it?
Yes, Doctor. Thank you, Commissioner. Also, just to note before I answer that question, we have realized that in the regional referral, when we integrated and we formed two, the acute care side and then the chronic side, the patients in the chronic sides are much more big in numbers than the acute side. So, and the staff that were given a bit thin on ground. So we need to look at that. In regional referrals, the chronic care patients are very big in numbers than the acute. Yet most of the people, the area manager, focused on the acute because they want these people to go away after serving them. In the infrastructure, we are emphasizing that we have the acute and the chronic side, and I think it's ongoing very well. We have harmonized, and there are particular leads, people who are heading each site. Maybe Dr. Andrew can add on to that.
We are running out of time, and it's already 9. We promised that we'll stop at 9. I would like to request the Secretary that any pending questions that you could have captured, please, we can have it addressed, responded to in our next session. For now, we may not go beyond this time because to discourage members from future attendance. So I thank you all. Team Lyra, the areas of gaps, please do your best. If you need any support from the ministry or any other region, please, through the ministry, can let us know so that we quickly close those gaps. Otherwise, you are doing a very, very wonderful work. On the digital tool, a lot is going on at the ministry in order to harmonize all those different tools so that we have, like at OPD, 2 main registers on acute care and chronic care. Our best to integrate work is going on, and we believe this will be finalized as soon as possible. Many people are asking about guidelines. This is still work in progress. And if, based on your experience, you have some good ideas that you think can help us to quickly expedite the process, please, it is welcome. Like we said, and like DG said at the beginning, we are in this together. So don't imagine that it's only the ministry to put those guidelines together. Your contribution is key and it's very, very important. So we all remain available at your disposal to support this process. So at this juncture, allow me now request our DG to give the closing remarks. DG, you're most welcome. Thank you.
Thank you, Charles. Thank you, Chair, and thank you, members. I definitely I want to thank you for that. We need to continue this discussion, but I like the spirit. I think this the spirit is good, that we need to be able to move this, and I think we should be saying no turning back, because sometimes we have moved to integration and then we end up by turning back. So we really need to be able to see how do we do that, because we really need to do patient-centered. This one patient can have a multitude of conditions, and he cannot be able to attend multiple clinics. So it drives satisfaction. Let's continue working on it. Let's have a feedback mechanisms. And I think let's also have the documentation mechanisms. So I hope, so far from the webinars we have had, we should be really having what is the frequently asked questions. We should be able to develop what are the frequently asked questions from the integration, and then we should be able, so that we don't keep, so that we just have answers for all of them, so for people to be able to follow. So thank you, Andrew, and thank you to your team. And also, I once again thank you to the team and the Secretariat for coordinating this meeting. And I also want to urge you that when we organize others, don't say for us in Lango we have had our session. So join them. I want to thank those ones who joined from the Gulu region, like from Kabale, from wherever. I want to thank them. So you join them, and let's continue the learning process. So thank you very much, and bye for now. So let's go and deliver the services we are required to deliver.
Thank you, DG. Thank you very much. Now, announcement. One, the next region to present is Moroto region. So if the Moroto team is here, please be informed that you are next. I think that is probably going to be next week or so. Then number two, we expect DHOs through the hospital directors to work together and do very good mobilization. In each and every meeting, we expect at least a minimum of 700 participants. But now we have been around 330 also, which is not even half of that. So please, we expect us to do much more. Otherwise, thank you very much, and we adjourn the meeting. Be blessed. Have a beautiful day. Thank you.
Good day.
Good day. Good day.
Hey, bye-bye.
Have a nice work.
I need to come to Lango for
Thank you,
Bueno.
and good day, Joe. Have a good day.
DG, you pass Gulu as well.
Bye. Okay, I will come there now. Okay,
Dr.
now.
Dur, we are coming to celebration there. You prepare. I hope you'll slaughter for us a good EGOT.
Thank you.
Commissioner Charles, you're welcome to